It was very good class. Yeah,
We
yeah,
are
thank you.
live.
So good evening, everyone. So in continuation with our immunology in infertility topics. So this is one of the topics which was requested by many, that is step-by-step evaluation of recurrent implantation failure. So this is a very frustrating situation for any fertility specialist, especially in IVF ICSI, when things have been so advanced with regard to the incubators, with regard to the availability of embryoscope, good media, and good stimulation protocols, good freezing techniques. Still, there are a set of patients or percentage of a couple who still end up in failed implantation. So, and I think this is one of those things which are either overdiagnosed or and under investigated sometimes. So, practical points in this is a little tough, especially for tier 2 cities, IVF centers where they don't have access to higher end probably like investigations like PGTA. I don't know actually what is the situation now. So let's know what is actually like, really important in evaluating, and what is the step-by-step evaluation as we are talking about oocyte factors, sperm factor, uterine factor, and also immunological aspect of this entire dialogue between the embryo and the endometrial cells. So you can take over and start, but basics we would really appreciate. Thank you.
Okay, done. Fine. So, we are going to try and discuss the evaluation protocol. This is only evaluation protocol, not treatment protocol, for recurrent implantation failure. Right? Now, in order to have a complete evaluation when a patient comes to you, so basically what is going to happen is the patient has had more than 2 failed ETs, and this is the patient who is going to come to you. So the first thing which you should evaluate in this situation was it a day 3 embryo or was it a day 5 embryo? This is important because remember, day 5 embryo is going to be the standard of care. All right, you can't really do a day 2 and day 3 transfer and transfer 3 day 3 embryos 2 times and say, oh, it is a recurrent implantation failure. Your first step in evaluating is that was it a day 5 or not a day 5. So basically, if it was not a day 5, then your target is to form a day 5 embryo. All right. Now, always go step by step. As far as the poor husband is concerned, just look at his parameters. Okay, broad semen parameters, and along with that, if not been done, kindly do a sperm DNA fragmentation index. The only special circumstance in this situation which can cause implantation failure is basically azoospermia. And remember, with bad semen parameters or a sperm DFI, in any of these situations, all right, if there is a recurrent implantation failure and if that is the only cause of failure, then your treatment of choice is to go ahead with testicular sperms. Okay, testicular sperms means husband's testicular sperms. Okay, fine. Then you look at the wife. In the wife, obviously you are going to look at the ovary, you are going to look at the uterus, and also try to look at the pelvis. Okay, in all these situations, in recurrent implantation failures, you will start getting causes one by one. Either it is going to be a case of low AMH. If not, there are many IVF centers who don't do AMH for their patients. Okay, so first rule out low AMH. Second is you are supposed to rule out poor quality of oocytes. Now, when I talk of poor quality of oocytes, majority of the times poor quality oocytes is going to be happening to the patient because of a poor stimulation protocol if everything else is fine. So make sure that your stimulation protocol is good in the next attempt. Let's assume somebody has had Antag cycle, switch to agonist. Let's say somebody has done agonist, you switch to antagonist. Let's say both have been done, you switch to a random start. Let's say there is low AMH, you do a double stimulation. So you will get your answers inside that. Okay. Along with this, you will also have a combination of ovary and the sperm, which is going to give rise to poor embryo quality. Now remember, getting a poor embryo quality is not a inferiority complex. It is a normal finding when you are doing many IVF cycles. So if somebody comes and tells you that I have never had a poor embryo quality, that means they are doing less than 5 IVF cycles or 3 IVF cycles in a year. They will never be able to accept what is a poor embryo quality. This is bound to happen. And one of the most important factors why a poor embryo quality occurs is due to something called as patient factor. And in the patient factor and in recurrent implantation failure, the most important thing which we have to remember, irrespective of your evaluation protocol, is your age of the female. All right. That is going to be a very, very important cause. But patient factor like very bad sperms, higher maternal age, very low AMH, all these can give rise to poor embryo quality. Of course, friends, never miss out your laboratory and culture conditions, because that is something which is very, very important. If your laboratory has not been optimized, see, you will never hear anybody say that I have a bad laboratory. It is below their dignity to mention something like that. But a person who is doing their laboratory work will know that laboratory and culture condition is very, very important for poor embryo quality. And that is something which you have to keep a very, very strong eye on as far as evaluation for recurrent implantation failures in your patient is concerned. And the third, which will affect the ovary very, very severely, is any form of endometriosis and ovarian pathology. Okay, this thing really, really affects the ovary. So just keep that in mind. After, let's assume there was nothing in the husband, nothing in the wife, everything was fine, but still there was implantation failure. That is when you switch your attention to the uterus. When you switch your attention to the uterus, the first thing which you are supposed to look is, was a hysteroscopy done or not? And also you can see if a 3D pelvis ultrasound was done or not done. Let's assume both were done and both were normal. It rules out a lot of factors. But in a country like India, you must keep in mind endometrial TB, very common in India. You must keep in mind Mullerian anomalies, especially septate, partial septate uterus, very, very common in India. You must keep in mind the fibroids which we really want to ignore. This fibroid, see? Fibroid touching the endometrium. We say, "Arey, nahi, kuch nahi hota hai. Guidelines did not support it, this, that." Simultaneously, you have to keep in mind this fibroid also. The large fibroid, which is subserosal, no? This large fibroid, when it is more than 6 centimeters, we commonly see this. We will see 2 patients like this every week. Fibroid 12 centimeter, embryo transfer done, patient did not conceive, 5 IVF cycles done. Next cycle, you do a myomectomy, 3 cycles after that, 4 cycles after that, she has conceived naturally. So, you must rule out all forms of pelvic pathology. So, pelvic pathology includes everything. It is fibroid, it is adenomyosis, it is endometriosis, it is prolapse, it is ovarian cyst. Everything has to be ruled out in your 3D ultrasound or pelvic scan. And of course, guys, always rule out something which is also very important these days, and that is chronic endometritis, very, very commonly seen as far as India is concerned. Commonly, please ensure that there is no hydrosalpinx. There are so many cases where you will have an occasional hydrosalpinx which is detected when a treatment has failed. Obviously, in that situation, you are going to require to do a salpingectomy and not just clipping. Okay, do a salpingectomy. That zamana where you do a clipping because you don't know how to do salpingectomy is gone. You call a good endoscopic surgeon, he will do it. But then these are the main causes for having recurrent implantation failure. If all these causes have been ruled out, now when you come to me and tell me that, "Arey Baba, I have investigated everything and there is absolutely nothing," then you should start paying attention to things like thin endometrial thickness. Was the endometrial thickness persistently less than 5.5 millimeter? Was the appearance of the endometrium not a triple line? Was there some previous surgery like adenomyomectomy or fibroid which was done onto the patient which has caused any of these problems? Let's assume you come back and state, "Chennai, everything else was fine. I evaluated everything and trust me, everything in the patient was fine." Then it comes to this, that your day 5 embryo, the quality of the embryo was probably an aneuploid embryo. So the next time you do the treatment for the patient, you are either supposed to do PGTA or NICS and first establish a euploid embryo. Before you start jumping, and before you start evaluating and commercializing things like LIT, IVIG, prednisolone, tacrolimus, we just spoke about all of this yesterday, intralipid. Before you start, saying that, "Oh, I give intralipid," you give, no problem. You even bath the patient in intralipid. But before that, you are supposed to ensure that the embryo is euploid. Okay? Because when you evaluate a euploid embryo, and if a euploid embryo has failed, and then there is RIF in a euploid embryo, that is when you start testing the patient for the entire recurrent pregnancy loss protocol. Like you are going to look at anti-nuclear antibodies, anti-cardiolipin, you are going to look at anti-beta-2 glycoproteins, you are of course going to test for APLA, you are going to rule out protein C, protein S, and you are of course also going to do karyotyping of the couple. And these days we also do a CDC cross match. And if all this is negative, then probably you can focus your attention towards giving experimental things in your practice, like prednisolone, tacrolimus. These days, some people are also experimenting with thymosin alpha, which has again got no role. And I'm going to give you an answer as to why it has got no role, because I have tried it in approximately 300 patients so far. Okay. So after you finish all of these things, that is when it should come to your mind that, okay, when these things I have evaluated in a patient with recurrent implantation failure and nothing has worked, okay, and if you have evaluated the protocol in this manner, husband first, wife, eggs, embryo, laboratory culture conditions done, day 3, day 5 done, uterus, everything evaluated, pelvic pathology ruled out, euploid embryo not seen. If you come to this as a conclusion, then remember, 98% of your cases with recurrent implantation failures where more than 2 implantations have failed in a country like India will get sorted. 100% it will get sorted. You will be left out with 2 or 3 or 5% of the cases where you will have to do lead investigations, follow-up investigations, more investigations, and you will come to an answer. But remember, even in patients with recurrent implantation failure, majority of the patients will turn out to be idiopathic. That means you will never be able to pick out a cause as to why there is an implantation failure. Your best bet in that situation is to make a euploid embryo. Because remember, it is this euploid embryo which will find its own path. A euploid embryo, when it goes inside the uterus, it will switch and stimulate the signals from the endometrium in such a manner that the endometrial alteration will be good. Endometrium will accept that embryo despite a pelvic pathology. That is the reason why patients who are unoperated for adenomyosis, there will be people who are unoperated for endometriosis, there will be people who have a large fibroid, there will be people who is having a hydrosalpinx, there will be people with endometrial TB. So many of them report natural pregnancies also. Correct? The reason for that being it was that euploid embryo which went in that focus of pelvic pathology. Also, it went and acted in that microvascular region, in that microscopic region so nicely that an implantation occurred and the patient got pregnant. Right? So the answer to that bottom line is such that no matter what you evaluate and what protocol you follow, nature will always be more supreme as far as implantation is concerned. One more thing I want to tell you, ERA, okay? No role. All right. We have stopped doing ERA since the last 20-24 months. There are certain indications which people may tell you that, PCOS, severe PCOS patient may have a skipped window, and extremely obese patients may have a skipped window. May be correct. I am not very confident about those indications. I don't do it even in patients pre or post bariatric surgery. Extreme obesity, BMI more than 29-30. Even if you think the patient is a best friend of yours, send them to a general surgeon or a bariatric surgeon for evaluation. Take it in written from them that currently bariatric surgery is not indicated or not recommended, and then do your IVF. In a situation and in a medico-legal scenario where we are living in, okay, it is always better to involve two more faculties rather than thinking that you will be doing everything on your own. And if you involve two more faculties, everything is going to be good for you and for the patient, and no form of medico-legal complications will occur in your practice. Okay, so with that I conclude, and maybe one or two questions or answers I can answer.
So what about endometrial scratching in recurrent implantation failure?
No role. No role.
What
No
about
role. Okay. No role of GCSF. No role of endometrial scratching. No role of PRP. Okay. PRP is also another procedure. It has got no role. It only acts on the hair. It does not act on any other organ in the human body. The more and more stem cells which I am doing, I am realizing that even stem cells is not having a very much great role. Okay, because we are not able to extract the endometrial stem cells, which is a very big problem. Okay, even in stem cell therapy, the more role is of hysteroscopy and very less role is of stem cell therapy. But remember one thing, stem cell therapy will act beautifully well when you have a chronically thin endometrium or when you have a Asherman syndrome. If you have a thin endometrium because of adenomyosis, it will not work. If you have a thin endometrium because of endometriosis, it will not work. Understanding? And remember one thing, all those people who are trying to fool the hell out of you by telling you, I do stem cells from adipose tissue. Okay, where you will get adipose tissue? Whose adipose tissue? Understanding? And if you try to do liposuction and remove adipose tissue from the arms or the tummy or anything like buttocks, whatever of the patient, you will have to remove so much adipose tissue to get a small concentrate of stem cells. So the current standard of care till we are not able to culture stem cell is to go for bone marrow. Okay. One more thing, remember, if you give GCSF injection before doing stem cell therapy, bone marrow will become empty. What you will get from bone marrow? GCSF mobilizes the progenitor cells from the bone marrow into peripheral circulation. So if you think you are doing a great scientific thing by giving GCSF injection 72 hours before bone marrow, it is the stupidest thing to do. It is like emptying the bank and then calling the robber, chal chal mera bank loot ke ja. Hai na? There is nothing going to be there inside the bank. You will only get platelets. Might as well do PRP in that situation. Understanding? So I know many people copy protocols, but they forget the fine points. No, copying is easy, but original is original. No, so that is the problem in that situation. So be careful even of that. Okay, again coming back, I don't think stem cells has a very much great role in recurrent implantation failure. I don't think so. And trust me, guys, I do a lot of stem cells when they are indicated. I have done lots and my patients have conceived. You can ask it to Shilpa GB or Aarti madam or whomsoever, and they will tell you, or even Debashish, and they will tell you the same things. Okay. One more thing we have to keep in mind. There are people who is going to try cute things, HCG injection, small microdose inside the endometrium. Somebody will go even cuter, more cuter, one step more cuter. They will put this HCG injection with embryo transfer catheter. Okay, it's very good. But remember, HCG will go and bind to the LH receptors which are produced on the endometrial cells. Understanding? Beyond this, the HCG receptor is not going to go and proliferate the endometrium. Okay, na? So everybody has its own limitations. Rather than putting it in the endometrium, give it in the blood. It's not like you can put HCG nose drops and suddenly endometrium will start growing. No. So be careful of all these practices which you hear from certain polished, fertility groups where only selected members are admitted and other people are not admitted. Be careful. Take everything with a very big pinch of salt. Okay, because at the end of the thing, the bottom line is RIF is very tough to treat. And in RIF, 90% of answers are going to lie in the initial part only. They will lie in the stimulation. They will lie in the sperm quality, egg quality, embryo quality, and laboratory culture conditions. Think of that first before thinking of all the fancy things. Understanding? Okay, I conclude. We can discuss.
Wait. Laser assisted hatching,
No role.
a co-culture,
No role. No
okay.
role.
So,
I know I
okay,
do
okay,
it,
fine.
but it has got no role.
Okay. So, in case if, say, the patient fails to form embryos at all, okay, I know we have discussed this
Do
in,
TVOD and stimulate in the next cycle with random protocol.
yeah, I think that was good. Yeah, I think that's about it. The rest we will discuss it on this thing. So you tell me, I mean, you said two if the embryo transfers failed. So you mean to say just two embryo transfers or two where you have proven with PGTA that they are.
No, actually, recurrent implantation failures, actual definition is when you have an euploid embryo. But
Yeah.
when I'm talking of a practical Indian situation, madam, you are going to get two IVF cycles failed. Patient will going to switch an IVF center. So they will come and tell you, oh, I had two embryo transfers. Okay. That is really very crude evaluation, but still that time you have to give the answer to the patient, no?
Mm. Yeah, fine. The rest we will discuss it on the WhatsApp groups. Thank you so much. It was very, very good. Thank you.